Good afternoon, everyone. Thank you for joining us for this afternoon special edition, 3 p.m. start time of our COVID-19 Professional Education Quickenar. My name is Matt McDonough, and on behalf of the End-Stage Renal Disease National Coordinating Center and CMS, I want to welcome you to this afternoon's event. These events are typically 30 minutes, and they are held in conjunction with CMS to convey COVID-19 critical information on a variety of topics. Today's is a special event which will be running 1 hour in length. And so for all of you who have taken time out of your day to attend today, we certainly do appreciate you being here. Now, before I do proceed to the next slide, which is our agenda, I do want to note that this event is being recorded and will be published on our ESRD NCC website in our COVID Quickenar section. We say that'll be within 72 hours or so, but we typically get it up faster than that, usually about 48 hours or less. So let me go ahead and advance to our second slide. Today's call, let's talk a little bit about what it's about. We are joined by 4 speakers today. We are very happy to have them with us. I'm going to go ahead and do their introductions now. You can see their names on the screen. And let me start with LaKeisha Jones, who is the Vice President of Clinical Services at Concerto Renal Services. She has more than 10 years of leading dialysis teams in both the chronic and subacute settings. She's responsible for providing a clinical atmosphere that values quality care, improved patient outcomes, and cohesion between all disciplines. LaKeisha has implemented clinical initiatives supported by evidence-based practice to help drive a strong clinical atmosphere and transform the patient experience. Recognized for her notable professional accomplishments, LaKeisha recently received the Top 25 Most Influential Black Women of Chicago Award. Next, we have Alan Jenkins, who is the Regulatory and Quality Manager at Concerto Renal Services. Now, Alan has 7 years of experience in the dialysis field and specializes in the regulatory guidance and quality measures. He's responsible for the creation of plan of corrections, policies and procedures, and assistance with state-guided surveys through all markets at Concerto Renal Services. Next, our second set of speakers will be led off by Alice Hellebrand, who is the Chief Nursing Officer of Dialysis Direct and was past president of the American Nephrology Nurses Association, or ANNA. She's been a practicing nurse specializing in nephrology and dialysis for over 30 years in multiple capacities that range from direct caregiver to director of renal service, area director, and education specialist. Her experience includes hemodialysis, home hemo, peritoneal dialysis, transplant designee, self-care hemodialysis, case management, nursing home care, and instructor for generic and online BSN School of Nursing. And last, we will have Thomas Schindler, who is the Director of Clinical Operations at Blue Central Group. Thomas currently oversees clinical operations, including, but not limited to, risk management, QAPI, regulatory compliance, and policy and procedure development for 7 skilled nursing facilities that are spread out across Ohio, Missouri, Pennsylvania, and Georgia. The topic of their presentation today is going to be COVID-19 dialysis unit strategies. And I've seen their slide decks, and it's going to be a very interesting presentation. As you watch this presentation and listen to this presentation today, please feel free at any time to submit your questions either via the chat panel, which should be in the lower right corner of your screen, or available from the WebEx menu, or the Q&A panel, which you can find in the same manner. Any of the questions that you submit at any time during our presentation, and I say that because you don't have to restrict yourself to the end, please send them in as they come to your mind. We will take some time at the end of our presentation today and answer as many as we can as time allows. So you may send a lot of questions in. You may not get a thank you. You may not get an acknowledgement, but we are watching these. We are going to be indexing your questions and getting them ready to be asked because we want to answer as many as we can today. So that's enough me talking. Let's go ahead and get to our first speaker slide, and it gives me great pleasure to turn the floor over to LaKeisha Jones.
Thank you, and good afternoon, everyone. We appreciate this opportunity to speak with you regarding our dialysis processes in the nursing home setting. Our patients in the nursing home constitute a vulnerable population Our goal as dialysis providers is to ensure we do our part with mitigating the spread of COVID-19 in our setting. Over the next few slides, I'm going to walk you through some processes we implemented to mitigate the spread in our setting. Next slide, please. Our guiding principles. Our patients, our employees, and our partners are very important to us. Even in the midst of a pandemic, we have an obligation to deliver superior care to our patients. As long as our patients were stable, we continue to provide dialysis to them in their home setting. Our employees. Well, not all heroes wear capes. Some wear Concerto scrubs. We provided our employees with COVID-specific training, and immediately before dialyzing their first COVID patient, our clinical team phoned the staff and had a conversation with them on infection control practices. They were reminded of performing hand hygiene prior to and after adjusting their face mask and or face shield, and removing their isolation gown, which was worn over their dialysis lab coat after initiating treatment and before returning to a clean area. We also used this opportunity to answer questions they had about dialyzing their first COVID patient. In the beginning, it seemed as though every hour of every day, COVID guidance changed. But every time we modified our policies and procedures, we were quick to communicate those changes to our staff. Our partners. At every juncture of COVID, we wanted to make sure we touched on the 3 C's: communication, collaboration, and coordination. So at the corporate level, we set up meetings with our partners to understand how they were going to tackle COVID, and we also wanted them to understand how we were going to handle COVID. We also shared our policies with one another. At the facility level, our managers connected with the administrator or the director of nursing on a daily basis to stay abreast of COVID changes within the facility. So at every level, we made it a priority to touch on the 3 C's regarding the processes for our shared patients. Next slide. Infection control practices. So at the beginning of COVID, we implemented universal masking for everyone entering the dialysis unit. For patients unable to wear a face mask, we provided them with a face shield. We also posted signage at the door noting the proper PPE that should be worn when entering the dialysis unit. All of our patients were screened prior to entering the unit, so the nurse performed temperature checks, and if the patient had an elevated temperature or presented with symptoms consistent with COVID-19, the nurse may determine that further assessment was needed and possibly sent the patient back to the floor for further assessment by the nursing home staff. Also, every patient came to dialysis with a communication form. This is how our nurses give report to one another. So we modified our communication form to include COVID-specific questions, such as the patient's COVID status. Is the patient negative or positive? Is the patient suspected of having COVID? Was a COVID test performed since the last dialysis treatment? And is the patient considered COVID recovered? So screening the patient was very important to ensure that we cohorted the patient on the appropriate dialysis shift. Personal protective equipment. PPE for our staff consisted of an N95 mask, a face shield, an isolation gown, which they wore over their dialysis lab coat, and a bouffant cap. So we trained our staff on how to doff and don PPE. We also created an employee portal that housed a lot of these education materials, resources that were available to our staff. So we had training material, videos, and instructions on proper infection control practices. Next slide, please. Infection control in the unit. So our units are terminally clean after a COVID shift and at the end of the treatment day. In addition to terminal cleaning, our staff used bleach solution mixed at the appropriate strength to clean frequently touched surfaces at the beginning of their shift, between dialysis shifts, and again at the end of the day. Suspected patients were cohorted with other suspected patients, and positive patients were cohorted with other positive patients. We typically dialyzed our COVID patients on the last shift of the day. If it's a 6-day-a-week unit, some of our patients were just dialyzed on a Monday, Wednesday, Friday, or a TTS schedule. We also crafted a COVID-19 infection control audit tool. Our clinical services team performed observation audits to ensure compliance of infection control processes. We also use this opportunity to re-educate staff and sometimes educate our nursing home staff as well. So as we continue to navigate through COVID and adjust to this new normal, our COVID practices will most likely remain in place as we continue to rely on science and evidence-based practice to do what's best for our patients and our staff, and also continue to be the provider of choice for our partners. So at this time, I'm going to hand this over to Alan, who is our Quality and Regulatory Manager.
Thank you for that, LaKeisha. If we could go on to the next slide, please. Okay, so I'm going to be discussing COVID-19 implementations that Concerto Renal Services obviously began at the beginning of kind of around the February-March period. The main thing is our COVID-19 tracker that we use to track staff when it comes to symptoms, return to work date, any comments associated with their return to work. So if we could just move on to the next slide. Thank you. So it's important to note, so everything on this slide is what's currently on the tracker as we use it today. When we first created the tracker, it only had the staff member's name, their role, their manager, the facility that they're mainly in, and then a section for comments. So as you can see, we added much more information that's really pertinent to making sure our staff are kept out of work for as long as they need to be, and then they're able to return to take care of our patients as soon as they are able and healthy. So I'm just going to speak on a few that are relatively important. So the date the symptoms first appeared, as we all know, is important to calculate the return to work date as long as they come back negative. Of course, their symptoms, the date, the need for testing communicated to clinical services. So clinical services was who referred all of our employees that were symptomatic to testing. Now, we wouldn't make the appointments for them, but we would find the closest testing facility that is most convenient to them, whether it be they're just getting off work or they're at home sick, so that way they're not driving too far in order to get tested. Of course, we have the date that they are tested, the date that we receive the results, the status, if it's ongoing, as if they're still out of work or they're still being followed up with clinical services on a daily basis. If they are positive, we had a section to make sure that they were reported to the health department, their expected return to work date as long as symptoms improved, and then their actual return to work date. So again, this tracker really, I think we've come up with a process to really formalize the best way to, again, keep track of the staff that were sick and or symptomatic, and then ensuring that they return to work with the adequate amount of time as outlined by the CDC. Next slide, please. So here's some resources from the CDC that were utilized, as well as some methods that we used as a company. So as many of us know, the symptom-based strategy from the CDC spells out that they're at least 3 days without fever and without the use of antipyretic medication, and at least 10 days since the symptoms first appeared. So this was, I believe this was the main strategy that we would use. And then, as you guys can see, the time-based strategy, I know the title for this one has changed quite a bit, but the time-based strategy is 10 days since the first positive test, assuming no subsequent symptoms developed. So again, this is more so for one of our employees that may have tested positive, but they're still asymptomatic. We would, again, still keep them off of work for 10 days as long as they continue to remain asymptomatic. A few of the methods that we utilize is that there was one main point of contact for employees. So that main point of contact would either be myself from our clinical services department, the regional manager, so the employee's direct manager, and then HR. So it's really a combination of those three groups that are keeping track of our employees as they are out sick with symptoms, or if they're positive out sick, just to make sure that someone's following up with them as much as they possibly can. We have and have a defined policy outlining the notification process, so employees know directly who to reach out to and what steps they need to take. We try and take most of the work off of the employees so that they can focus on getting better and focus on, you know, just resting, so long as they don't have to really hone on, oh, where am I going to get tested? We usually take care of all of that for them. And again, this cuts down on the downtime from testing to results because we are able to utilize outside non-PCP testing agencies. The main ones we used were North Shore Health Systems, Midwest Express Clinics, Walgreens, Physicians Immediate Care, and I believe that's it. And then lastly, for telehealth utilization, a lot of you may know that when it comes to nursing homes, they limited the ability for most of our physicians, social workers, dietitians to actually physically go into the nursing home. So at Concerto, we utilized telehealth in the sense that we took advantage of phone visits, video conferencing, stuff like that, Skype, anything that can allow those mainly physicians, allow them to still see their patients while following the nursing home's guidelines as it relates to COVID-19. That is going to wrap up the Concerto portion. I just wanted to thank the NCC for the opportunity for us to discuss the various COVID-19 implementations that we did. Thank you.
Thank you, Alan, and thank you, LaKeisha. And please don't go anywhere because we are receiving questions that are coming in. And this will serve as my reminder at this point to state again, if you do have questions for any of our speakers at any time, and I've seen a few that have come in, please do send them to us. We will be taking time after our next segment to ask our speakers questions that you submit and get as many of them answered as we can at the time allows. So that takes us to the start of our next segment, and it is my pleasure at this point to turn things over to Alice and Tom for the Dialyzing Direct segment.
Hi, and thank you all for attending this webinar. I really appreciate the ability to present of what we're doing from the dialysis perspective, as well as from the skilled nursing home, and how we are mitigating the COVID-19. I mean, these are unprecedented times, so it's really, really challenging. Next slide, please. Okay, so we're going to identify the methods for mitigating the spread of COVID-19 in the nursing home setting, and we're also going to discuss the benefits of in-house dialysis related to minimizing exposure to COVID-19. It was a challenging time, and we all know that. And one of the things that I think we need to really realize is how it impacted our dialysis patients, our ESRD patients. And we know that right now, end-stage renal disease patients, those individuals with chronic kidney disease undergoing dialysis, had the highest rate of hospitalization among all Medicare beneficiaries, with 1,341 hospitalizations per 100,000 beneficiaries. Patients with ESRD are also more likely to have chronic comorbidities associated with increased COVID-19 complications and hospitalizations, such as diabetes and heart failure. And we know that our patients are the most challenging. They're immunosuppressed, they need dialysis, and providing that dialysis to these patients living in a skilled nursing home is definitely a priority, because from Dialyzing Direct's perspective, it is really home is the best for our patients. And traveling outside to an outpatient dialysis unit, although the care is wonderful there, I would never debate that. I came from that world. I think the care inside the facility it is really appropriate for them. And we know it's home dialysis. Next slide, please. So since COVID began, you know, we've learned an awful lot. We've learned a lot. And so one of the things that Dialyzing Direct is really focusing on is our research project. So from the time that COVID came on the scene back in February, in New York, one of the epicenters there, Dialyzing Direct had facilities that we were providing care in. And we realized immediately that there was, you know, it was an unprecedented time. And certainly that we did not know what to do. I mean, COVID was new for all of us. We had no idea. We thought it would pass really quickly. We'll throw on some PPE. Patients might get a virus. They may go back to the hospital, which we didn't want them to do. But we were going to be able to care for the patients. I think in a way, or I believe in a way, that the dialysis personnel that we had hired, and we hire only experienced personnel there, already had the experience of PPE usage. It was not something that we necessarily had to train, although we had to support. Maybe there was some remediation in there and a reminder, this is what you were preparing for your entire career. We're very well versed in putting on gowns and wearing masks during our treatment time, washing hands, as we all know, in infection control practices. That's what we do. We're hit on that survey all the time. So we continued that implementation of cleaning the chairs, cleaning the space, being mindful of what we were doing, changing gloves, washing hands, wearing the masks during our treatment. So that part was really wonderful. We began immediately as this virus attacked us and came into existence of looking at the demographics of our patient and calculating and getting the data that was needed. So from March 1st, 2020 to 6/23, the last time that I have the data, which was fairly recent, we dialyzed over 1,300 patients, treated and performed over 40,000 treatments. In all, symptomatic patients were 343. Now, we tracked all symptoms that the patients had. We went from cough to temperature. As the virus spread and we were alerted that a stomach ache or an eye infection could be related to COVID, we definitely expanded our breadth of how we were looking at these patients. But the 343 were the core symptoms that a patient would present with. In all of our facilities, and we have over 100 facilities in 10 states across the country, we had 111 patients that were tested positive. I think that says a lot about the care that was given and what was going on in the skilled nursing home, because we were able to decrease the spread of the disease, virus, many times. For Dialyzing Direct, we had 30 staff members that tested positive, and we have over 450 staff members. And in all of the sites across the country that we were providing care to, non-ESRD patients, who were positive, 83 of those 100 in over 100 facilities had non-dialysis residents who tested positive. I'm going to turn it over to Tom right now with some of his data.
Great, thank you. I appreciate the opportunity to speak with everyone and collaborate here with Alice. Again, we have 8 facilities throughout the United States.
Tom, I'm sorry to interrupt. Is it possible that we could get a little bit louder? I know I'm having a little bit of trouble hearing, and I'm not sure if that's possible.
Is that loud enough?
It sounds pretty distant, to be truthful.
How about now?
Can you hear him now?
I very, very faintly, unfortunately, and I don't know if I'm the only one, but I'm hearing very faint and distant.
How about now?
That's a little bit louder.
Okay.
Okay, I'll try to speak as loud as I can without yelling.
No, I think you could yell. That's fine if that's what works.
Okay. So again, we have 8 facilities that operate in multiple states. We operate in Ohio, Northern Ohio, and South Ohio. We operate in Georgia.
I'm sorry, Tom and Alice. I'm sorry to interrupt again. We're getting some messages that are saying people can't hear.
Okay, let me try to, and I apologize. I hear Tom in my background, so there's a little. So Tom operates through Blue Stream Central Group. They have 8 facilities across the country, and they are in nursing homes. They have facilities that have dialysis on site, and they also have facilities that do not have dialysis on site. So right now, they had only symptomatic patients or patients who are positive in the numbers of 3. I'm sorry, 25. Tom's talking to me because he's unable to hear. So of those 25 patients, 22 COVID positive was related to facility-wide testing localized in one area. And what they had was also 9 staff who tested positive, who were all asymptomatic but tested positive based on contact tracing as a result of community exposure. In his building, there were no dialysis patients, and we are a provider for dialysis in his buildings. He did not have any dialysis patients that tested positive. He had dialysis patients that were going to the outpatient facility that did test positive in separate buildings, and it was assumed, and we don't know, I mean, we could make that relationship, that many times it was a dialysis patient who might have been the first contact in the building who turned up positive. So it was really challenging for them from the perspective of decreasing the amount of exposure for the patients in the building. Next slide, please. Okay, so how do we mitigate the spread of COVID in the skilled nursing home? Well, Dialyzing Direct partners with skilled nursing facilities, and we collaborated the care. We were very, very fortunate in the model of care that we provided in the skilled nursing home, that we do 5 days a week, Monday through Friday, dialysis treatment, and therefore it permitted us to screen our patients and our staff a bit more efficiently, and certainly micromanage them because we were able to have that face-to-face interaction with the patient and our staff on a daily basis. One of the really differences about what was happening is as we looked across the country, what was occurring in New York was not necessarily the same that was occurring in Illinois or Indiana or in Texas. And even at that point, the same thing is happening. And so to keep up with all of the changes that were occurring, not only from CMS, but also state to state and facility to facility, was something that we partnered with all of our skilled nursing home providers that we did. One of the most challenging things was that the regulations for ESRD that would occur in the outpatient dialysis world and the skilled nursing home facility, they were not necessarily aligned because there was this ever-changing of what to do for a resident that was in a skilled nursing home and also what we were doing for the ESRD patients. So in the collaboration with Tom, with his group, we decided and made the recommendation, and we collaborated to take the highest level that we possibly can. And that was combining the regulations for the skilled nursing home along with the ESRD and for the CDC, of course, the CDC guidelines on how to care for our patient. Testing was a struggle. There were, in many, many nursing homes, there were over 100 patients. And all of those 100 patients who were definitely not ESRD patients, they presented different strategies. How were we going to make our dialysis patients and not single them out or carve them out from the general population, decrease that exposure for them? And so that's where our collaboration came in. Any patient in the skilled nursing home who presented with symptoms and were symptomatic based on CDC guidelines, we provided through the skilled nursing home a test. Now, keep in mind that test, I'm not quite sure even today what that test means. We had patients, dialysis patients and residents who tested positive one day, and we wound up doing another test like 3 days later. They were negative. 3 days later than that, they were positive. And we had this cycle that was going on. We had residents in the skilled nursing home and also dialysis residents who continually tested negative. However, they had symptoms. Many of our patients, of course, were on vents, and it was very challenging to determine whether or not their symptoms were due to the vents and their respiratory issues, or if it was COVID related. So in collaboration with the skilled nursing home, we decided to consider that every single patient that was in the building was a patient that was susceptible and actually COVID positive. And so we saw no difference between the two groups, and they were all PUIs for us. And therefore, every patient that was in the building, or every dialysis patient that was in the building, from the moment that they left their room to come for services, they needed to have a mask and be in PPE. And so was anyone who's transporting that patient. We also required that any patient, dialysis patient, who is receiving treatment must wear a mask continuously, as well as our staff. Now, we supplied our staff with N95, with the head coverings, full PPE. We did practice sessions to make sure everyone was washing their hands well. We added additional supplies into all of our facilities so that we could decrease that spread. And we believe that we were very successful. The skilled nursing home partnered with us to monitor our dialysis patients because we really had two goals in mind. And I want to say those two goals are really, really important to me for any patient. One, that they do not get COVID, and two, that it's not necessary that we send these patients to the acute care hospital unless the skilled nursing home, in collaboration with the dialysis provider, Dialysis Direct, was able to manage their symptoms. And we did. We know that the acute care hospitals were overrun with COVID patients. Our dialysis patients were also at risk because we also know that in the acute care hospital, they were lacking sufficient staff that knew how to dialyze a patient. One of the things that I heard, at least in the New York area, is that they were bringing caregivers in, or anyone takes someone who is retired who were out there to provide care to the patients, especially since AKI was on a rise. So that was definitely something that we needed to look at. And the collaboration that we had with the skilled nursing home was incredibly valuable and very, very important to our patients. Next slide, please. Okay, so in accordance with the CDC guidelines, we implemented everything that came out. We continuously sent memos not only to our staff, but we had calls with Tom to discuss how any change that we needed to do. We screened our patients continuously. The skilled nursing homes screened their patients on a daily and actually a Q shift. We screened our patients from day one, as I mentioned, when they came into the dialysis den prior to treatment. And one of the great things then, I really think that that dialysis patient could not have had any more screening. And they were very, very receptive to that. I was concerned. They'd say, why am I doing this? Why do I need to be screened so much? Why am I somewhat of an outlier? And they actually embraced that. And I believe, and I've heard from many skilled nursing homes, that their non-dialysis residents were actually asking for the same care that the dialysis resident was receiving. Our staff was screened immediately upon entering the building as they stepped foot into the skilled nursing home. If they showed with any symptoms, they needed to leave immediately. And then when they came into the dialysis arena, Dialysis Direct also screened them again. So they had a two-step screening to make sure that they were not bringing in any COVID into the building that could possibly be exposed to all the rest of our staff and also skilled nursing home staff and the residents. It was really important to us that we cared not only for our patients, but we also cared for our staff. Having staff come down with COVID in many, many instances meant that they needed to be quarantined for 14 days. And at the beginning of all of this, it was really challenging to get them tested. There just wasn't enough tests out. In the meantime, since this has evolved, many of the skilled nursing homes, and certainly Tom's group there, has begun screening in their facilities, and it really changes state by state. I could say in Florida, they have mandated that for all staff, they need to be tested twice a week. It is a challenge, but we are adhering to it. In many other facilities, one such as Tom, what they've decided is that if a resident or a staff member becomes symptomatic, they will test that person. And if someone tests positive, they will blanket the entire skilled nursing home. And everyone is tested at that time, and then they'll be tested weekly until all staff members and residents come back with a negative test. In many locations, what we're doing is somebody tests positive, patient or staff, we will wait 10 days, and then we will do a two-step test within 24 hours of each. And as long as they're negative, then we could pull them out of the COVID positive status. For those residents in the building who did show with active symptoms or tested positive, we cohorted those patients. We either provided bedside care, one-on-one, or if they were brought down to a communal room, patients who were asymptomatic and tested negative were on our first shift. On the second shift were patients who tested positive or symptomatic, and we kept those patients 6 feet apart so that there was no cross-contamination until we were able to get a two-step negative test for all of our patients. And I believe that that also decreased the spread of COVID in the skilled nursing home. One of the concerns that we had in the skilled nursing home is that, you know, our patients, some of the patients that were there, and certainly sites that we went into after COVID and provided that on-site dialysis, is they might say, you know, I'm here in this building and everything that's out there, all the talks that we had out there was that this is a hotbed for COVID, and are they at risk for here? And we know that there were skilled nursing homes that have been in the news where COVID just ran rampant throughout the building. And yes, some of our dialysis patients were affected by that, no doubt. And I hope in the future we have placed in processes and protocols and procedures that will minimize that. But the patients that we provided care to along with Tom, it was really, really interesting that we were able to slow down that spread, and these patients actually felt better. They were they replied to us that they were tested twice. They were tested by the dialysis center. They felt as if they were not being exposed by going outside the building. And so I think that really decreased the numbers, and you could see that from the demographics that I presented much earlier. And so all in all, I think we've done very, very well with decreasing that, adhering to CDC guidelines, and certainly partnering with a skilled nursing home for that unique patient population that's like no other. These are the frail, the elderly, the patients who are living in a communal center, unusual situations. They did not see their families. Many did not have visitors. Just as my colleagues from Concerto mentioned, telehealth was utilized so that we could have that interaction between social workers and renal dietitians and physicians on a much more frequent basis because we're able to use that telehealth and have that connection with the patients. Next slide, please. And so what are the benefits for these patients for residing in the skilled nursing home? Well, we had more frequent testing. We were able to provide that dedicated care and eliminate that outside travel exposure that the patients would have. whether it would be in the transportation or different sites or just moving back and forth. And we also had the dedicated equipment to the patients, and we had dedicated COVID-19 testing was readily available. And as you may have heard in the news, the CDC or the states have given and supplied the skilled nursing homes with testing, and it also includes the ESRD and the dialysis residents that are out there. I think I'm good. I see a lot of questions coming through, and I see some of my names on them. I don't know if I should just answer those or...
Well, Alice, we'll go ahead and we've got a bunch that have come in through both parts of the presentation, so kind of been indexing them and keeping track of them. Before we start getting into those questions, this would be a reminder to everyone, if you do have additional questions, please send them in through our chat or Q&A panels. We do have about 14 minutes or so for questions, but we do have quite a number of questions to get through. So I'll jump in, and if I know the question is for someone, I'll address it to that person. If it's a general question, I'll leave it open for both speakers to answer. The first question that I saw was for Alice, and I think you did answer this, but there's some clarification needed. Who provided the PPE to your dialysis staff for the staff going to skilled nursing facilities that were providing services? It sounds like that the organization did, but they wanted to clarify.
Sure. Dialysis Direct, upon noticing what was going out like that, we ramped up our supply chain. Our logistics was able to increase the number of PPE, including N95s, the Buffon caps, gowns, gloves, and provide that in the skilled nursing home. That is a requirement of the regulations for the dialysis provider to supply everything that's needed for the treatment.
Very good. Thank you. Thank you for clarifying that. I think this one is for you as well. You mentioned both bedside and second shift in the dialysis facility for positive patients. The question is, why is one versus the other?
Sure, and really good question. And so in a skilled nursing home, we might have a communal room that patients could receive dialysis. And so we would ask the majority of our patients to come down to that communal room. Those that were asymptomatic or negative would run on the first shift. Those that were COVID positive would dialyze on the second shift, and that gave us the ability after they left to terminally clean that room, do a thorough cleaning. The patients that we provided care to on bedside, that was a unique population in this subgroup. Many of the patients that were coming from the acute care hospital were really debilitated. Many were on ventilators, and they still had not been weaned, or they were patients that would be chronically on ventilators and unable to come down to a communal room. And so those patients who with very, very high comorbidities who could not sit in a chair for the length of the dialysis treatment or needed that one-to-one were done at bedside.
Very good. Thank you. Thank you so much for expanding on that. This is a question for both speakers, or all speakers, I should say, since we had more than two. And this is, I think, is a good question related to how capacity was handled. With surges and limited nursing capacity, were your organizations able to comply with the home RN requirement, or was there a need to expedite training for nurses? And they're referring to the less than 3 months home RN training requirement.
We were extremely lucky that we did not need to deviate from the home requirements for RN experience. We had ample staff. We were able to maintain our staff to patient ratios during the entire COVID time. That is nothing to say about me. It's kudos to the team that we had on board. And we are very fortunate that we only hire experienced nurses so that we don't need to do that training. So we were incredibly fortunate. And to that, I just, for any member of Dialysis Direct that's out there, I have to say thank you. Nurses, we rise to the occasion. And so we were very successful with that.
And LaKeisha or Alan, I don't know if you have anything you wanted to add to either of those.
We were quite successful with our staffing. It was something that we monitored at every level. Alan, he tracked our employees that were out sick, those that came down with symptoms. We actually got them tested quickly and followed the CDC guidance and were able to get them back to work right away. We also reached out to previous staff that worked with us before. So we kept a lot of staff in our back pocket. We stayed in contact with staff that had worked with us previously. We also utilized some staffing agencies. So we were quite successful with keeping our staff on board and having staff during the COVID-19 surge.
Very good, very good. Thank you both for sharing that with us. LaKeisha, this one I'm going to direct towards you, and it's more of a staff type question. If you had a patient that tested positive with asymptomatic positive, and they were transferred to a COVID clinic, do those staff who came into contact with that patient get tested for COVID automatically? Is that a policy, or how is that type of situation handled?
So our staff were screened at the beginning of their shift, and at the midway through their shift, and again at the end of their shift. If they presented with symptoms of COVID-19, we would surely send them for testing. If they were asymptomatic, we did not test them if they were caring for a COVID positive patient. Alan tracked our staff symptoms, and he also is the one that sent them out for testing. So we did not test those staff members that came in contact with the positive patients unless they developed symptoms that were consistent with COVID-19.
Very good. Thank you. Thank you for answering that. I'm going to go back to Alice for this question. This is a clarification question. I think somebody did you state that you cohorted positive patients with patients under investigation, and were they symptomatic?
Sure. We considered every patient that we provided care to as a PUI patient. That was the bottom line. So we took extra precautions with every single patient in every single episode that we provided dialysis with. We cohorted positive patients, those that had tested positive, and away from the patients who are asymptomatic or negative. But any patient that we came in contact with, we wore full PPE, and we made the presumption that they were positive because the tests were unreliable.
Very good. Very good. Thank you. Yep, thank you very much. That did answer the question. This is a question that I'll open it to LaKeisha, and then if Alice, if you want to provide additional information, this is for any speaker. Can any of you provide insight on controlling COVID-19 and an SNF with on-site dialysis centers that are open to both the skilled nursing facilities and community patients? Is that a situation that you had encountered, I guess, is the first part of that question. And then if so, how would that have been controlled?
So how do we control COVID-19? Well, the practice that we mentioned during our presentation in regards to how we mitigated the spread of COVID-19, those practices were in place. Those practices allowed us to mitigate the spread, to stop the spread within our setting. We are on site in the SNF. I'm trying to, I guess, understand more of this question. Are they referring to how we mitigated the spread in our dialysis unit and how it impacted patients that went out to the community?
Well, I think if I'm understanding the question right as well, and if the person who asked that question wants to clarify in the chat window, we would encourage that. It just seems like this particular facility is
Yeah.
open to both skilled nursing or patients from the skilled nursing facilities and the community, and if there's some sort of, I guess risk of cross contamination from that scenario.
Right. So there are operations that are considered outpatient. They're outpatient facilities that they happen to be on the property of a skilled nursing home. So they bring patients from within the building, but they're also, because they're separate licensed, they're not a home dialysis center. They're really outpatient, that they're able to take patients from the outside. I'm familiar with those, and we have many in my area. So I believe that they would do the testing just as you would for any patient. In the waiting room, patients would need to have social distancing. They would need to be tested prior to entering the actual dialysis facility and receiving care. And I believe from everything that I've heard that they're also cohorting patients. Many, many times in the areas, they have patients and separate facilities for negatives so that there's not a mixture of the two.
Thank you, Alice, for jumping in and taking care of that. So it's an outpatient dialysis facility that's on site at the SNF. Okay.
Yep, and I believe that did answer the question, because I see in the chat that that was what was being asked. So thank you both for providing some insight on that question. This is a general question about creating an in-house unit, and I think the question that we'll ask it is from a now that a COVID perspective here. Any recommendations for creating an in-house unit? They have 7 residents that undergo dialysis and have additional. Can serve additional. They considered building additional capacity on site and even a mobile unit. In light of that situation, though, and then in light of COVID, what are recommendations if they wanted to proceed? How best to do that?
Well, for us, I think our Concerto team is on. We would just need to, we actually have people in place that are responsible for our emerging markets. They are responsible for marketing and growth of the company throughout different skilled nursing facilities. And so if we have the name of the facility, certainly we can reach out to the person, or they can also reach out to Concerto.
Very good. And in general, for everybody who's online and that question that was asked through our chat, we will provide information. These slides will be available at the end of this presentation tomorrow on our website. So you'd be able to get more information and contact information through that as well. This is a general question. Is there a patient-to-nurse ratio, for example, dialysis patient to RN, in your nursing home setting? And I'll ask that question of Alice first.
Sure. We do our nurse-to-patient ratio based on the patient's acuity, but typically it is 1 nurse for 2 patients, unless we're doing bedside where the patient is really a higher acuity, say a vent patient with multiple comorbidities that needs that dedicated care, and then it's 1-to-1. We really believe that the majority of the patients that we're seeing from the skilled nursing home are direct admits from the acute care hospital, and their presentation requires that dedicated and precise care. For those sites that might have patients that are, as we call, not as high comorbidity, they're not demanding as much from an RN, and we have an RN in every one of our buildings that is an employee of Dialysis Direct with dialysis experience. We may go a little bit higher to 3, but we always then have 2 caregivers in the room. One is always an RN.
Excellent. Thank you. Thank you for answering that. We appreciate that. I have a question. I'm just curious, Alice. You had mentioned during your presentation that there was the hospitalization rate, if I heard right, was 1,300 plus for every 100,000 patients. Is that correct? And given that there is a resurgence of COVID in some areas, you know, in Florida, Arizona, can you provide some context on that rate based on the standard rate that we're observing in non-patients to know what may be anticipated during this second wave?
That's a tough question. It really is, and I appreciate it. I mean, this is really coming from CASER and KCP. I'm a member of Medicare Partners, and so we've been actively working to present data that's out there. What I'm hearing from your question is it going to rise in ESRD patients, or is it going to stay level, or are they more susceptible or more likely to develop COVID? I don't know. I think we've put in place many processes and procedures, and we have the knowledge right now on how to protect not only our patients, but our staff, certainly PPE. I can't say enough. I'm surprised that more dialysis patients in the skilled nursing home did not turn COVID positive, and I think it's because of the care that we provided. Now, I know in the, in other facilities and other non-home patients, the rates can be higher than in the skilled nursing homes. Also keep in mind that there's a lower percentage of patients who are receiving dialysis at this time, and I'm sure Concerto and I would agree that we're hoping that that increases receiving dialysis on site. The benefits are definitely outweigh anything that could be negated.
Well, thank you so much for answering that as best we could there. It is a influx situation, and we understand that things are changing all the time. We are coming up on the end of at the top of our hour. So LaKeisha, Alan, Alice, and Tom, I know you're out there. I just wanted to say thank you so much for joining us today, for sharing your experiences and your thoughts. The NCC, on behalf of the NCC, I just want you to know we really appreciate you being here. So thank you.
Thank you.
And we're going to go ahead and you're welcome. Thank you so much. We're going to go ahead and advance to our wrap-up. We just want to talk a bit about the kidneyhub.org. It is a secure, mobile-friendly web tool for patients and professionals. And when we say mobile-friendly, it is designed to be accessed and viewed on a smart device, such as a smartphone or a tablet. Our patient subject matter experts that work with the NCC helped us develop this. And as you can see on your screen, there are a number of resources that are available for patients, and contact information and video education and information on grants. So as always, we encourage you to take a visit out there on your smart device, see what it's all about, and see if there's something for you out there. Our next COVID-19 Quick and Our events, they are next week. Our patient-focused event is July 7th. That is Tuesday, 5 p.m. Eastern. And our provider-focused event reverts to its normal time, as usual time, I should say, which is 5 p.m. Eastern on Wednesday, July 8th. Those events will be available for you to register out at www.kidneycovidinfocenter.com, where you can see information on those events and to register. And for those of you who didn't get your questions answered today, if you'd like to submit them to us, you can see our email address here on the screen, and we'll convey those that we can to our speakers today if they're so willing to address those. Our telephone information is on the screen as well, and our website. And you see two websites for additional information on COVID resources. That's casecoalition.com and again, kidneycovidinfocenter.com. There are COVID resources on either of those sites that you can access if needed. So again, on behalf of our speakers on the ESRD NCC and for CMS, I just wanted to say thank you for your time today. We appreciate you being here, and we certainly hope to see you on a future Quick and Our event. Have a wonderful afternoon. Take care.